I will now give the floor to Professor Yamut, and he is co-chair together with Professor Oreja-Guevara. Professor Yamut, you have the floor.
Thank you. Hello, everyone, and welcome to this combined session between MENACTRIMS and ParadigMS. It's my honor today to co-chair this session along with my dear colleague, Professor Celia Oreja-Guevara, who's also president of ParadigMS. Now, we've been doing this activity on a yearly basis. We started last year, actually, as a pre-MENACTRIM activity, which is a full-day symposium coming just a day before our MENACTRIM Congress. But of course, this year, everything went virtual. We even had to cancel our actual MENACTRIMS Congress. So we decided to keep this up and having this combined Paradigm MENACTRIMS symposium on a virtual basis. So our symposium today will be divided into two parts. The first part will be basically a radiology discussion with case presentation and open discussion. And this session has been very, very popular in the past with all of our neurologist colleagues. And the second part will be addressing the issue of women in the field of MS, and a little bit we're going to be touching about the issue of COVID-19 and multiple sclerosis. Next slide. So MENACTRIM stands for the Middle East and North Africa TRIMS, which is similar to the ACTRIMS of Europe, the ACTRIMS of North America, the PACTRIM of Pacific Asia, and the LACTRIM of Latin America. It was founded basically in 2016 and has been since the major association in the Middle East North Africa region, taking care of MS as far as patient societies, as far as education, providing yearly research grants, and even this year we started providing fellowships for young neurologists that want to train in MS abroad in Europe, in Northern America, and so on, similar to the ACTRIMS fellowship. So MENACTRIM has been quite active for the last 4 years and has really now its place among all the international scientific MS society. Next slide, please. I think I will leave that to Celia if her connection is better now to talk a little bit about paradigms. Celia, are you with us? I'm not sure about Celia's connection.
Celia, you're on mute at the moment.
Professor Yamut, I propose we just, Professor Oreja can take these slides when she starts her lecture. So
okay, fine then. Then we can move to the first part of our symposium today, which is the neuroradiology part, whereby we will gonna use a case presentation format. It's my pleasure to introduce both Professor Roula Hourani, who is an associate professor at our university, American University of Beirut, and is a neuroradiologist, and Dr. Jens Würfel, who works at the University of Basel, Switzerland. So they will be presenting cases, short lectures, and please consider that as an open discussion. Feel free to ask questions, and we'll have some time at the end for more questions. Please, Roula and Jens, the floor is yours.
Thank you, Basel.
So I will now stop sharing the screen and give the floor to Dr. Würfel.
The screen sharing is still deactivated on my end.
Okay, I will activate it then. That's no problem.
Yep. Very good. So it's my honest pleasure to say hello to everyone. And of course, to start the session with my co-chair, esteemed speaker, Professor Roula Hourani. We're both very excited to give you some hands-on news based on many, many cases, as you will see. But we especially aim to trigger lively discussions with you, the participants, and to learn from each other. I have no specific conflicts of interest to this talk. Neither has Professor Hourani. And as a starter, let me directly jump into some images and ask you, well, seeing 4 different patients here, what's your estimate? Which of these patients suffers from MS? Please give me your votes. You have the option, the possibility to vote here. I expect to see about 13 votes. Is that right, Stefan?
I would expect 9 votes, yeah.
Okay, that's very nice. We have a nice distribution here. Give it another minute.
Yeah, we have 6 replies, so that's more than 50%. So we have, actually, we should expect, yeah. So I'll end the polling now.
Very good. Thank you. So before I give you some results or conclusion, think about why you selected, why you decided here. And let me a little bit guide you. I have to move my, cannot see the whole screen at the moment. Let me give you some guidance. Oh, that's already the solution. I was too fast. Well, as you can see, I cheated. There's none of these cases is an MS case, but all of them could be. Of course, there are some slight hints, and you will learn by the lecture today or the discussions today what the hints are, like being more subcortical, being in the basal ganglia, the morphology of the lesion differs, etc. But there are many, many differential diagnoses talking about white matter lesions, and the aim of today is to guide you a little bit through and to give you some more confidence on how to diagnose MS. Basically, a T2 lesion hyperintensity is something very unspecific, can be part of an edema of demyelinization or even of axonal loss. We cannot differentiate that based on a T2 lesion. There are some characteristic findings, and you will retrieve them later, of MS. So MS lesions are usually quite well delineated, round or ovoid. We have frequently periventricular or subcortical or U fiber lesions. We usually don't see mask effects in these T2 lesions in MS. For the last years, and I've been working on that for the last decade, the central vein sites is something very specific, highly specific to MS. So based on the pathophysiology that there's a perivenous inflammation. So the T cells need the restimulation by antigen presenting cells which are in the perivascular space. And that is the reason why lesions usually start surrounding a vein. And so the central vein site is something very specific, as is the hyperintense rim that you can see if you have like higher field strength and T2 star weighted imaging. And with that, I hand over to Roula. Okay. Should we, how should we proceed? Would you like to set up your own screen?
Yes, that's the idea, yeah.
Okay, so I stop here.
Okay, good evening. I'm very happy and excited to be part of this webinar, and thank you for inviting me. So I will be speaking now about the MR diagnostic criteria for diagnosis of multiple sclerosis. So multiple sclerosis, MR play a crucial role in the diagnosis of MS. The diagnosis of MS is based on the demonstration of typical white matter lesions with characteristic of dissemination in space and time. MR also is used to exclude other neurological conditions that can mimic MS. MR also is very important to estimate the disease burden and to differentiate active demyelination from chronic demyelination by using contrast-enhanced MRI. So enhancement is a sign of active demyelination. Now for the diagnostic criteria of MS, the diagnosis is made by a set of criteria that we call the McDonald criteria. And those criteria, they were set up over the years. We put they first came out in 2010 and 2001. Then they were revised in 2005, then in 2010. And for a long period of time, the 2010 McDonald criteria were used for diagnosis of MS in research and clinical practice. However, there has been a lot of scientific changes and advance in the last 7 years. And we suggest that those 2010 criteria might no longer provide the most up-to-date guidelines for clinician and researcher. So this is why now we have to use the 2017 McDonald criteria. There has been some changes between the 2010 and 2017 McDonald criteria. And the change mainly includes the usefulness of CSF-specific oligoclonal bands. Also, we include the use of symptomatic lesions and the cortical lesions also for demonstration of dissemination in space. So those are the recommended revised 2017 McDonald criteria for demonstration of dissemination in space and time by MRI. And mainly we use them in patients with a clinically isolated syndrome. That means we use it mainly in patients presenting with optic neuritis, transverse myelitis, or brain stem symptom. So for the dissemination in space, we should have one or more than high T2 signal lesion in at least 2 of the 4 typical CNS area. And here the change from 2010 to 2017 was the inclusion of both symptomatic and asymptomatic lesions. So we should have 1 or 2 or more lesions in 2 of the 4 CNS area. So the typical location are the periventricular white matter, the juxtacortical white matter, and we're including now the cortical lesions, presence of spinal cord lesion and infratentorial lesion. So if we have lesions in 2 of those 4 locations, we have the criteria for dissemination in space. Now for the dissemination in time, if we have simultaneously presence of gadolinium enhancing and non-enhancing lesion at any time, and this also will include both symptomatic and asymptomatic lesion, we have the criteria for dissemination in time. Or if we have a new T2 lesion or enhancing lesion on a follow-up MRI, irrespective of the baseline MRI, so this is also a criteria for dissemination in time. Or if the patient doesn't have those 2 criteria for dissemination in time, now the McDonald criteria use the oligoclonal bands in the CSF and promote the use of the presence of oligoclonal bands in the CSF. So if they were present and positive, this will replace the dissemination in time. So if we have the both criteria, dissemination in space and in time, we can say that this patient most likely has MS and will develop a second attack in the future. I will emphasize also on the 2016 MAGNUMS MR criteria. So MAGNUMS recommend also MR criteria for diagnosis of MS. For dissemination in space, they recommend the presence of at least 2 of 5 lesions in 2 of the 5 areas in the CNS. So here they recommend the presence of 3 or more periventricular lesions. And this is different from the McDonald criteria, because in McDonald, we only request the presence of 1 periventricular lesion. In the MAGNUMS, they requested 3 or more periventricular lesion. And like the McDonald, presence of one or more infratentorial lesion, one or more spinal cord lesion, one or more optic nerve lesion, and this is different from the McDonald. They add this fifth anatomical location to do the diagnosis dissemination in space, and one or more cortical or juxtacortical lesion. So, but we recommend the use of 2017 McDonald criteria versus the Magnum's 2016. And why? Because changing the requirement from 1 to 3 periventricular lesion improved the specificity from 0.3 to 0.4 to say that this patient will develop a second attack in the future. So this modest improvement did not justify the complexity of requiring more than 1 periventricular lesion. And that's why in the now revised McDonald 2017 criteria, we maintain the requirement of just 1 periventricular lesion. However, there is one exception in older patients and those that they have vascular risk like migraine, hypertension, diabetes. So those patients, they have a lot of white matter spots. So in those patients, the clinician should seek to see more higher number of periventricular lesions. So in those cases of patients at risk factors, migraine, hypertension, and diabetes, we can use the criteria of 3 periventricular lesions. The second difference between the Magnums and the McDonald was the addition of the optic nerve involvement as the fifth anatomical site, but this also led to minor improvement in the sensitivity to predict a second attack from 0.991 to 0.92. Therefore, the McDonald criteria 2017 did not incorporate the optic nerve involvement as a criteria for dissemination in space. So we kept the McDonald criteria simplified as the previous one with the new added 2 criteria that are the presence, the usefulness of symptomatic and asymptomatic lesions, and we add the cortical lesion. So as a key point for diagnosis, MR diagnostic criteria for MS, early diagnosis of MS is based primarily on clinical evidence. Although the diagnosis of MS is increasingly based on MRI and CSF, but it always required the judgment of a clinician with expertise in multiple sclerosis. We recommend the use of 2017 revised McDonald criteria that revitalized and promote the role of CSF analysis and the presence of positive oligoclonal band. And also we added the 2 imaging findings that were not included in 2010, which are the symptomatic lesions, they count for dissemination in space and time, and the presence also of cortical lesion. So the McDonald criteria show the dissemination in space and time in a simplified and unified approach. And also, we recommend the use of MRI, high quality and high standard quality MRI, the use of new sequences like double inversion recovery and phase-sensitive inversion recovery. So those sequences, they help us to see better the cortical lesions, which now are used criteria for dissemination in space. So now I stop sharing and it's Jens' turn.
And as always, in radiology and MRI, there are some pitfalls to respect, some technical pitfalls. For example, those that arise from T2 and the strong signal of the CSF. Some lesions you just miss, you cannot see on T2, and that is one of the big advantages. We're all aware of the flare sequences that suppresses the CSF and makes especially these periventricular or ependymal lesions very clearly visible. There are some other pitfalls to speak about, but let me first introduce you to this case, 2 scans with a year apart. What do you think about the disease activity? Actually, I would appreciate to also see your faces so we can have an active teamwork here. All participants, if you don't mind. What do you think about the disease activity between these 2 slides? Any comments? Well, sometimes it's very hard to delineate the lesions. And if you have like the same parameters over time and nicely put slices, you can do subtraction imaging and reveal those areas of activity that otherwise you may miss, just as a hint. Same question to this patient here. Again, a year apart, and I'd like to ask every one of you to vote. How do you think, what is the situation longitudinally? Oops. Okay, expect a poll. There's the poll. Okay, obviously there's some activity in between, is what you think. So what do you do based on these results? I have to admit I'm a neurologist and a neuroradiologist, so I'm interested on the clinical part as well. What do you think? Would you change your treatment regimen based on imaging, on these imaging findings? Yes or no? Okay, that's very interesting. Majority says yes. Let me add one question. I'm quite sure we don't have a poll for that. Or repeat that question. You would, if there's no clinical progression, you would still change your therapy based on these imaging? Probably the answer is yes, right? Okay, let's finish the poll. You see, you have to be quick with this, also in voting. Okay, now here is the issue. If the slice repositioning is not perfect, and usually it is not, the slight difference in the angulation of the slices may bring you to results that you don't like. And that is especially true if you use gap in your sequences, or if you have thick slabs and not 3D isotropic 1 millimeter, what you in clinical routine usually don't have images. And that might resemble or cause a seemingly progression of disease. And if you really base your treatment regimen on that, might be problematic. So please be aware of these pitfalls. And that is why we request, or you should request from your radiologist, to use always constant conditions. Use one MRI scanner for longitudinal monitoring, strictly adhere to the identical parameters of your sequence, the identical orientation, the identical slide positioning, and that way you avoid trouble as just shown you. If possible, use a 3D flare isotropic sequence. It will facilitate you the retrieval of lesions, and especially longitudinally help you enormously. And with that, I hand back to Roula.
Okay, so now we'll start the case presentation. So this is the first case. 43-year-old male presented with gait imbalance and urinary retention. His EDSS score is 0, and this is his MRI. So we have axial T2 images at the level of the brainstem, at the level of the medulla, pons, and middle cerebellar peduncle. And we have a sagittal flare of the brain. So we have lesions seen in the lateral, posterolateral aspect of the medulla, see lesions at the peripheral aspect of the pons, lesions here also in the middle cerebellar peduncle. And those are the flare images. So in our institution, we use a 3D flare, isotropic thin cuts, 1 millimeter 3D flare, and we use also a software. We do 3D linking when we want to compare the two images. So this is a response to Jens' comment. When we want to compare two exams for the follow-up of the patient, we do 3D linking. So the two 3D flare images are linked together, and we can compare. We have the images in the same axis, in the same plane. So we have better comparison, and we don't have those pitfalls and misleading. So in this flare, we have lesions at the level of the callososeptal area. So lesions in the corpus callosum, lesion along the temporal horn, so mainly periventricular lesion. And this is a T1 gadolinium image. The lesions here also, we have a lot of periventricular lesion with like ring enhancement, incomplete ring enhancement of some of those lesions. Again, sagittal flare, which is the most important sequence in MS, this 3D thin cut sagittal flare, where you can identify also those cortical lesions, so juxtacortical, but also cortical lesions that are one of the criteria for dissemination in space and time. So in this patient, we have lesions, cortical lesion, we have periventricular lesion, we have lesions at the posterior fossa. So here, this patient fulfilled the McDonald criteria 2017 for dissemination in space. For the dissemination in time, we have at the same time in this T1 gadolinium image, lesions that enhance and lesions that do not enhance. So here we have the criteria for dissemination in time. So this patient fulfilled the McDonald criteria for diagnosis of MS. We did the workup for this patient. His laboratory tests were negative for infectious or other autoimmune etiology, and this is always should be done. For the CSF study, the oligoclonal bands were positive. So patient was diagnosed with MS and started on Avonex. And we have a follow-up MRI 6 years later that showed the disease was not active, and we didn't have other new lesions or active inflammation. This is a follow-up flare and T1 GAD. There is no active lesion on the new MRI. So MS by far is the most common demyelinating disease. It appears between the age of 20 and 50. Approximately 10% of cases appear after the age of 50. It's more common in female. The etiology still unknown, probably autoimmune. A patient usually present with acute transient neurological attack. The diagnosis should be based on the clinical history, on the physical exam, laboratory test, mainly CSF, and MRI. The typical appearance characteristic MR appearance of MS lesion were discussed previously by Jens. I will not go again over those lesions. So typical location periventricular lesion, cortical, juxtacortical lesions, with a Dawson finger appearance of the lesions along the path of the medullary veins. And we have enhancement on the active inflammation and demyelination. So T1 gadolinium is important for the diagnosis of MS. Now we can use advanced imaging technique also to help in the differential diagnosis or to diagnose MS in difficult cases. So MR spectroscopy, just a small briefing, what does it mean, MR spectroscopy? It's a non-invasive technique to evaluate chemical metabolite in the brain. And we have main 3 metabolites that we see in a normal spectrum. So this is a spectrum from a normal patient. So we have the N-acetyl aspartate at 2 ppm, which is a neuronal marker. So NAA is a neuronal marker. So if you have a neuronal loss or neuronal dysfunction, you will have decrease of this NAA. Then at 3 ppm, we have the creatine. The creatine, it's an energy marker, and we use it like a buffer usually. And then we have at 3.2 choline. Choline, it's a cell membrane marker. So choline is increased mainly in tumors where we have a lot of cells formation. So when we have cell membrane formation synthesis, we have increase of the choline. But you should pay attention that in active demyelination, if you have destruction of the myelin in the acute phase, in the active phase of demyelination, because of the degradation and destruction of myelin, you might see increase in the choline. So increase in the choline is a hallmark for tumors, but also you can see it in active demyelination, but you don't see it usually in chronic demyelination. Another important marker that's useful in demyelination is myoinositol, that we see it usually at 3.5. We don't see it except if we have increase in astrogliosis. So it's a glial marker, and we see it if we have astrogliosis. So this is a MR spectroscopy from patient with a chronic MS. So if we put a voxel into a chronic plaque of MS, we see that we have, so this is the voxel, at 2 ppm, you have decrease of the NAA, of the N-acetyl aspartate, because of the destruction of neurons or dysfunction of neurons because of the demyelination. And we can see increase of the myoinositol at 3.5 ppm because of the astrogliosis. This is a voxel from a normal appearing white matter. And even though multiple studies, they show that even in the normal appearing white matter, you can see some decrease in the NAA in MS patient because the myelin is not totally normal and it is dysfunctional. So the neuron, the NAA, which is a neuronal marker, is a little bit decreased. Now we move to the case number 2. The second case is about a 47-year-old female. She developed first in the year 2000 bilateral blurring of vision, followed by vision loss in her eyes that was completely reversible after ACTH injection. In August 2017, she presented with right hand clumsiness and numbness, progressing for 10 days. And 10 days later, she developed significant weakness and limb ataxia. And this is her MRI. So here we have axial T2, axial flare image, axial diffusion, and the ADC map. So we see this left parietal lesion, high on T2 and flare. It has a rim of high signal on diffusion, but the center is not restricted on the ADC map. So as you see, the center of the lesion is high on the ADC map. This is the T1 and the T1 gadolinium. And here you have incomplete C-shaped ring enhancement of this lesion. This is the MR perfusion of the same patient, and you see that the lesion has a low relative cerebral blood volume. So the MR perfusion show us the neoangiogenesis in a lesion. For example, in a brain tumor, you should see high RCBV because you have new vessels formation, neoangiogenesis. In this lesion, the RCBV was low. And this is the MR spectroscopy. We put a voxel into this lesion. And here you can see that you have high choline into this lesion. And we have lactate because of necrosis in the center of this lesion. So after we view all the images of this patient, I would like to ask you, what's your diagnosis? So is it a low-grade glioma? Is it a lymphoma? Is it a tumefactive MS or an abscess? So what do you think? So the pool here is also have 4 of 13. Okay, so we'll wait to have the complete vote completed. Shall we stop the vote? Because I think, well.
Okay, we will stop the vote. Yeah.
Okay, so most of you got the correct diagnosis. So it is a tumefactive MS. One person said that this is a lymphoma. And the reason that it's not a lymphoma, because lymphoma, usually they enhance a lot. So on T1 gadolinium, lymphoma, they enhance strongly and homogeneously. But this lesion does not enhance strongly. You just have a small peripheral rim of enhancement. So the imaging on enhancement on T1 gadolinium does not fit the diagnosis of lymphoma. And for one of you that they said that this is an abscess, the reason why it's not an abscess, because on diffusion, the center of the abscess, we should see restricted diffusion because of the presence of pus, and that gives a lot of restriction of the water motion inside the abscess. So in abscess, you should see restricted diffusion in the center of the abscess, and the ADC map is very low. In contrast, in this lesion, on diffusion weighted image, so if I close the poll, I can go back. Oh, I cannot go back to the, okay, to the diffusion weighted image. So this lesion was not restricted in the center on diffusion weighted image. The center has high diffusivity. So there was no pus into this lesion. So the correct diagnosis is a tumefactive MS. The workup for this patient, including blood test and CSF study, were only positive for oligoclonal bands. But still, the neurologist did not believe me that this is a tumefactive MS. So they insist the patient will have a craniotomy and biopsy. So the patient had a craniotomy, and this is the result of the histopathology. They found a lot of macrophages with reactive astrocytosis, occasionally periventricular lymphocyte. So the findings were most suggestive of demyelinating disease, but still they couldn't eliminate other processes like infection and less likely lymphoma. So the patient took steroids during her acute relapse and improved dramatically. And this is the follow-up of the patient after 2 months. Of course, we see here the result of the surgery. So we have some surgical changes, surgical cavity, with some area of gliosis surrounding the surgical cavity, but the lesion has completely resolved. So the key points about tumefactive MS, that usually it presents like a solitary lesion mimicking a neoplasm. So usually it mimics a GBM, a high-grade glioma, or a lymphoma. It can involve the corpus callosum because it's a demyelinating lesion. Usually it has more than 2 centimeters, it is more than 2 centimeters in size with incomplete ring of enhancement. So this is very important in the diagnosis, the incomplete peripheral rim of enhancement. On MR spectroscopy, as I showed you, you might see increase in the choline. Of course, choline, we see it mainly in tumors, but in tumefactive MS, because of the active demyelination and destruction of myelin, we can see also increased choline. And this is here a very important point that MR spectroscopy cannot differentiate between tumefactive MS and tumor. However, the most important sequence here is MR perfusion because it's very helpful. It will show us low RCBV. So as I said, the cerebral blood volume reflects the neoangiogenesis, the formation of vessels within a lesion. So in tumors, we have increased RCBV, but in tumefactive MS and other demyelinating lesions, we don't have neo vessels, formation of new vessels. So the CBV is low, and this is the key diagnosis in tumefactive MS. And usually tumefactive MS respond to steroids. Those are, I have also 2 other cases of tumefactive MS. So this is the first MRI, flare anti-1 gadolinium, a large lesion enhancing, mimicking a glioma. And this is the follow-up MRI after steroid treatment. And you see that the lesion decreased significantly in size, no enhancement. And you can see here the hint, the presence of another periventricular lesion. Another case of tumefactive MS, periventricular typical lesion involving the corpus callosum, enhancing like a lymphoma, but the CBV, the cerebral blood volume, is low, so it's not just suggestive of a tumor. MRS, as I said, is misleading. It shows high choline like tumor, so disregard the spectroscopy, don't look at it. And this is the follow-up MRI 3 weeks later with no treatment. There is complete resolution of the enhancement. So it's not a tumor, definitely not a lymphoma, because the enhancement resolved by itself. And you have here another periventricular lesion suggestive of demyelination. Now I move to the third case. This is a 29-year-old female. Patient developed a sudden onset of left-sided hemiplegia 1 month post-delivery. And this is the MRI of the patient. Here we have a T1, a T2, T1 with gadolinium. This is T1 gadolinium, sorry, there is a mistake here. So this is a T1 GAD. So we have some patchy peripheral enhancement. And this is T1 without gadolinium. So lesion in the right centrum semiovale. And this is the diffusion weighted image of this patient. So look at the ADC map. The center of the lesion is not restricted, but you have here some hint for the diagnosis that appears on this ADC map. This is the MR perfusion of the patient. Sorry, this is the RCBV. Here, we should put the RCBV here and the flare here. So this is the CBV, MR perfusion. Again, this lesion show low RCBV, so there's decrease in the cerebral blood volume. No angiogenesis, so it's not suggestive of a tumor. And this is the MR spectroscopy. We have a high peak of choline and the NAA is decreased. So what's your diagnosis? Is it a low-grade glioma? Is it a tumefactive MS? Is it an abscess or concentric ballosclerosis? So what's your diagnosis?
We will end in 15 seconds.
Okay. So here are the results. So most of you got it correct. So this is a concentric sclerosis of Ballot. And the hint for this is the presence of those concentric ring of high and low signal on T2 that we better see on the ADC map, on the diffusion weighted image, but also on the T2 images. It's not an abscess because, as I said, on the ADC map, the center of the lesion is not restricted. Restriction should show us high signal on diffusion and low signal on the ADC map. And it's not a low-grade glioma because this lesion, it shows enhancement, peripheral, ill-defined enhancement. So if it is a glioma, it should be a high-grade glioma. And it's not a high-grade glioma because the CBV, the cerebral blood volume on MR perfusion, is low. High-grade glioma should show very high CBV, a CBV of 4, of 6, or 10. So this lesion is not a glioma. It's not an abscess. It could be a tumefactive MS, but the appearance is mostly of a concentric sclerosis of Ballot. So we did the CSF study for this patient. It was positive for oligoclonal bands. Other tests were negative for MS mimickers and hypercoagulable state. So it's a case of Ballot concentric sclerosis. The patient took steroids during acute attack and started on Tysabri. Follow-up after 2 years, MRI. I show you this is the follow-up. So we have here some sequelae, residual high T2 signal in the right centrum semiovale, but there's no enhancement. The resolution of the most of the lesion, no enhancement after contrast administration. So there is disappearance of the lesion with sequelae of neuronal loss of this, if you want to call it a hole, in the right centrum semiovale. So Ballot concentric sclerosis is a rare and severe monophasic demyelinating disease. It is considered as a subtype of MS. It appears as a rounded lesion with alternating layers of high and low signal intensity on MRI, giving its characteristic bullseye appearance or the onion bulb appearance. Usually the clinical presentation is similar to other forms of MS. Pathologically, we have concentric layers of alternating demyelination and preserved myelin as seen by imaging, resulting in this characteristic appearance of onion bulb appearance. So the MR imaging characteristic appearance, as you see it here on the diffusion, we have those concentric rims. So here we have a rim on the ADC map, you see it better. So the center is high on T2, then you have a rim of low signal intensity, then a rim of high signal intensity, then a rim, a second rim, a fourth rim of low signal intensity. So those concentric rings or irregular stripes of high and low signal on T2 are very characteristic of Ballot concentric sclerosis. On T1 gadolinium, typically we have a peripheral ring, incomplete peripheral ring of enhancement, as shown in our case, demonstrating the area of active demyelination. And on diffusion, we have some restricted diffusion in the outer ring, like in this case. We move to our fourth case. It's a 30-year-old patient, male patient, presenting with optic neuritis. So this is an axial spear with gadolinium at the level of the optic nerves. So this is a T1 fat SAT enhancing T1 image. And here we see enhancement along the optic nerves, right optic nerve and left optic nerve. And this is the sagittal T2. I put it for you like a hint, a sagittal T2 stir, T2 with fat SAT, stir at the level of the spinal cord. Here I don't have a poll, so I go directly to the diagnosis. So this is a case of neuromyelitis optica. It is a demyelinating inflammatory disease. It was thought first that it's a variant of MS, but here in the last years, we consider it as a separate disease. It involves the spinal cord and the optic nerve with optic neuritis, demyelination of the optic nerve. The characteristic appearance of neuromyelitis optica at the level of the spinal cord is the longitudinal extensive T2 spinal lesion that is more than 2 segments. And some people also, they request more than 3 segments in length. And the lesions in the spine are very hyposignal on T1 because they are necrotizing. So we have a necrosis in the spinal cord and the lesions are hypo on T1. We have abnormal signal enhancement in the optic nerves. And in the chronic stage, we have atrophy in the optic nerve. The distribution of brain lesions in the NMO are characteristic and correspond to the site of high aquaporin 4 expression. So mainly we see the lesions in the brain near the ventricles surrounding the third and fourth ventricle and in the periaqueductal gray matter. And in NMO patients, 60 to 90% of patients, we have serum anti-aquaporin 4 antibodies positive. And in 20% of cases, we have serum positive anti-MOG antibodies. Jens, would you like to add anything for the NMO patient?
No, not at that stage. There's still a lot of discussion development ongoing. Maybe one short comment. Because in the recent years, NMO was considered as NMO spectrum disorder with patients included that were aquaporin 4 positive and those that were not positive. Now with the discovery of MOG antibody disease or associated disease and other antibodies to come, I think there's a slight change also in how we see NMO and NMOSD, and probably for the future or even for the moment, we should define those patients NMO that are aquaporin 4 positive clearly, and be open to shift those that are negative to other pathophysiological background.
Okay, thank you. So now we move, this is another case of Devic neuromyelitis optica, just to show you the long segment of involvement in the spinal cord. So this is a sagittal stir of the spinal cord, showing a long segment of involvement involving more than 3 vertebral body in length, and the typical lesions in the brain surrounding the fourth ventricle and surrounding the third ventricle. We move to our fifth case and last case for this session. So this is a 15-month-old patient with decreased level of consciousness, fever, and complex partial status epilepticus. He was admitted to the PICU, and those are his images. So we have axial T2 image of the brain. So we have lesions in both hemispheres involving both thalami, involving the white matter as well as a gray matter. So lesions are asymmetric and bilateral. So what's your diagnosis? Is it an acute encephalitis? Are those post-ictal changes? Is it ADEM, acute disseminated encephalomyelitis, or acute necrotizing encephalitis? So what do you think?
We close in 15 seconds.
Okay, so all of you got it correct. So this is ADEM, acute disseminated encephalomyelitis, which is very frequent in kids. Usually after an infectious, after an infection, a viral infection or vaccination. The workup for this patient demonstrates MOG positive antibodies, probably post-infectious ADEM. The LP showed 26 white BCs. All cultures were negative. So we did the diagnosis. We consider it like a MOG antibody disorder associated ADEM. The patient was treated with steroids and IVIG, given 2 divided doses and continues after 2 days. And we repeated the MRI. And this is the follow-up MRI. And we see that we have complete resolution of the lesions 1 month later, and the patient was discharged home in a stable position. So the key point about MOG-associated disease, so myelin oligodendrocyte glycoprotein antibody disorder is an idiopathic inflammatory demyelinating disease of the CNS. So it's a new entity. MOG is a glycoprotein uniquely expressed in the oligodendrocyte in the CNS. MOG antibody disorder have many similarity to MS and neuromyelitis optica, but several studies have demonstrated that is a distinct disease. It has several clinical presentation, and the most common similar to NMO, as Jens discussed it before. So NMOs with negative aquaporin 4 antibodies, probably they are in the MOG-associated disease. And this mainly we see it in adult patients, so the presentation as NMO. Another common presentation of MOG-associated disease is the presentation as ADEM, acute disseminated encephalomyelitis, mainly in the pediatric population. Now, some key points about ADEM, acute disseminated encephalomyelitis. So it is a monophasic, a self-limited and demyelinating disease, usually with a complete recovery in 1 month. The etiology is autoimmune mediated. So usually we see it after a viral infection or a vaccination. And the mean age is in the pediatric population between the age of 5 and 8, and it has a male predominance. And by MRI, we see multifocal white matter lesions, but also deep gray matter lesion, like in our case, lesions in the thalami. It can involve the brainstem, the posterior fossa, and the spine. And the treatment usually is immunosuppressive, immunomodulatory therapy, and plasma exchange therapy. So by imaging, we see bilateral asymmetric lesions in the central white matter of variable size. They can be confluent in one hemisphere. We have involvement of basal ganglia and thalami in 25% of cases, and we have enhancement in 25% of cases. The enhancement can be either punctate or ring enhancing lesion or incomplete peripheral ring of enhancement. In 1/3 of the cases, we have associated cord lesion with a long segment of involvement. Usually it's monophasic, but still we have a lot of tricky cases of ADEM with relapse during the 3 months. This is another case of ADEM, so typical bilateral asymmetric lesions involving both gray matter, basal ganglia, thalami, and white matter, and the enhancement pattern can be homogeneous or incomplete C-shape enhancement, ring of enhancement. ADEM can involve also the spinal cord, another case of ADEM with involvement of the spinal cord, long segment involvement in the spinal cord, and lesions bilateral asymmetric in the white matter. So here,
Roula, before we go to the bio break, may I distract you for a second? Because I'm fascinated by these thalamic lesions that you see. And I wanted to curiously ask you about thalamic lesions and MS. What do you think? What is your experience? Do you frequently see thalamic lesions in MS?
In MS, we see it not very frequently, but in our institution, in the MS center, they did a study about volumetric measurement of the thalamus and the basal ganglia in patients with MS, and they found that there is decrease in the size of the thalami in patients of MS, and this is suggestive of underlying demyelination and a neuronal loss, even though we don't see it probably on the FLAIR image. So in patients where we don't see lesions on FLAIR, but still there are lesions involving the gray matter and the thalami mainly, and the study showed decrease in the size of the thalami in MS patients.
Yep. Great, thank you. I just a couple of days ago had a discussion with a histopathologist, neuropathologist on thalamic pathology, and he confirmed that thalamus lesions are quite frequent. but very rarely we detect them by conventional means, by conventional MRI. We do see them with 7 Tesla MRI or some specific
sequences. Of course, yes.
Not in the routine so frequently, and we underestimate what is there in pathology. But as you said, the atrophy is quite distinct in MS and frequent. Okay, thank you very much. I was just curious. Shall we have a very quick bio break? Stefan, is that with
Yes, yes, for 5 minutes. So I would say that maybe 20 past the hour, we reconnect, and then there are more cases that will be presented for the second part of the workshop. So speak to in 7 minutes then.
Wonderful. Okay, I think we are ready to restart. And I'll go back to the initial MS patients 5 years after. You see the yearly MRI that we did in this patient. And very obvious, there's some increase in the T2 lesion load. Now the big question is, so what? Do we care? Very initially you said you saw some lesion increase. Well, yes, definitely, and let's change the diagnosis. I'd like to get you to a point, well, we skipped that one, to a point to explain you why individual lesions even are important. If you look at the disability worsening after 2 or 3 years, there's a high correlation between individual lesion, and it starts, as you see here, with one individual lesion that is new, or was new in this patient, that correlates with the increase in disability, if you look statistically. So yes, stopping the disease as good as we can is very important, and that is why for us radiologists, this task that we hate, counting lesions, has clinical relevance. And I wanted to motivate you to tell you, well, yes, please do so. This is important information. Now, here we have one of these patients. It's not 1 year apart, but 10 years apart. The patient, meanwhile, is 58 and is on interferon therapy. And there's some slight increase in lesions, very obviously. Oops. I will skip. The question was again, okay, sorry, misunderstood that, Paul. The question to you is, well, now it's 10 years apart and you do see some new lesions. How do you do in clinical practice? What does that tell you? If the patient is clinically stable and you have a subclinical progression in MRI, I'd like to hear some opinions from you. What would you do? Well, that's obvious. I explained that already. Thank you, Stefan.
Okay. Apologies.
We see that, but the more important question is, well, what does it trigger? The patient is on interference. Any opinions? You can open your mic. You can type in the chat if Stefan lets you.
Yes.
Do you have any opinion? So if it was your patient, what would you do?
Please open your mic and answer. It's okay. It's no problem.
I don't bite. And there's no right or wrong decision at that stage. I know that from my clinical practice. So the question is, I'd like to have your experiences and your opinion here. No clinical change, clinically stable, slight progression in the lesion count. Is that a reason to change therapy for you? Yes or no?
Well, I will answer just to encourage him, Jens. If I see 2 or more lesions on the MRI while the patient is on treatment after 1 year, I would probably escalate the therapy.
Okay, and if it was 10 years in between?
No, that would be different, of course.
It's 10 years in between. So,
yeah. Right.
Still change the therapy?
10 years, no, that would be different. I would probably wait if the patient is clinically stable for 10 years. 2 more lesions will not probably make me change my mind as far as the treatment. But this will be different if it was only after 1 year of treatment.
Yeah, absolutely, and I agree with you. The colleagues that this case was that transferred the case to me, well, they did change the treatment. They changed from interferon to fingolimod at that situation. And the patient consented, obviously, in that. Now, having these 10 years in between and knowing getting some more information, the patient has hypertension, high cholesterol, and quite some therapies that may reflect also, well, side effects that you, not only side effects, but additional reasons for white matter lesions. Are you still convinced to change your treatment is the question here. Does it change your opinion? Okay, let's give it's 1 year apart to facilitate your decision. And you see that is a typical problem that we have not in the 20-year-old first diagnosed patient, but in the patient that suddenly has a progress or not at the age of 50 plus. And it's very important to understand that at a certain age, not all lesions, T2 lesions that we see are MS derived. So there are additional diagnoses that influence what we see, and it's difficult, and we need to take some time to differentiate these lesions in our patients as well. Okay, I think we can stop the poll and move on to the next slide. Now, 1 month after the imaging, and the imaging was just a routine follow-up, the patient developed a nasocilia neuralgia. So pain when moving the eye. And I just gave you the anatomical background here again. Is that in line with the MRI? Oops, let's go back. MRI I showed you here. So how do you link that information? You know that often lesion appearance precedes clinical symptoms. I haven't opened a poll. I thought we haven't opened discussion yet. Okay, so it's a tricky question. The question wasn't that, they didn't solve the question because all symptoms vanished a month later. And they repeated the MRI, and this is the MRI they came up with. So now I do want to have some honest opinions from you. What do you think about this MRI? By whatever means, please respond.
Jens, this is December 2017, right?
Sorry, it's December 2017. Yeah, that is a mistake on my end. Yeah, sorry.
Okay.
That's absolutely correct. Didn't even notice. So it's like 2 months or later.
I think we have an answer in the chat by Muhammad Badr.
You're muted, Jens.
Jens, I think you're muted.
Okay, sorry about that. I'm struggling with the technique. I couldn't see the chat. Can you read the chat?
Yeah, it's a stable MRI. Few new small white matter lesions appeared.
Okay, that's correct. And there's one prominent lesion. Let me encircle that. And that is in this area. Do you see that? There's obviously a change within these 2 months. Now, how do you relate that to the symptoms that the patient has? It's difficult. You cannot relate it, but there's a new lesion. Now the colleagues did what I would have done in that moment as well, even though the patient was not natalizumab treated, but fingolimod treated. They tested for JC virus, and the result was negative. So what do you think now? It's a tricky and real life case. Now, this is just the initial scan to show you that this lesion indeed is a new one, and it evolved quite quickly.
Was it enhancing?
I don't have I haven't received that level. No, it was not enhancing. So okay. All information I have is here, is the T2, and it was not enhancing. It has diffuse borders, quite sharply delineated towards the gray matter, diffusely towards the white matter. It's a little bit inhomogeneous in appearance, and very quickly growing. And no, I come to that later. Okay, so these are some of the typical features of a PML that you have to think about in that situation. Now, the reason why everyone messed that up is that this lesion is asymptomatic and has ever been and stayed asymptomatic, whereas the lesion that caused the neuralgia, that is that one here in the brainstem, and they overlooked that in the initial scan. So this is the initial scan from October, and the patient had a clear new MS lesion in that area. But he, in addition to that, developed a left hemispherical PML lesion. Now, how can we distinguish PML from MS lesions? One way is by shape. As I said, MS lesions are ovoid, PML is more diffuse, MS well circumscribed, PML usually ill-defined and quite sharply in the very beginning to the gray matter, then it also infiltrates into the gray matter and very diffuse to the white matter. And PML lesions are fast increasing in size. Now, here is another clue to it. Usually MS lesions are central. The majority of MS lesions are periventricular or central, whereas the beginning of a PML in the vast majority is in the periphery. And so just to give you some red flags, if you see a lesion that is growing quickly, that is in the periphery, that is diffuse to the white matter and in the beginning sharply delineated to the gray matter, this is a PML lesion. Thank you, Stefan. I will delete that one again. And some more clues. So here's a nice 7 Tesla image. And again, you see a PML lesion in that area. And if you have the chance to have a T2 star SWI in a 3 Tesla machine, I know it's not a clinical routine, you may use that to differentiate those lesions that are PML derived from those that are MS derived. MS lesions have the central vein. PML lesions do not have that. Now, one additional feature, and that is why I highly appreciate if in clinical routine we use diffusion, not only for diagnosis, but routinely. Diffusion sequence is about 2 or 3 minutes. It's so helpful and so nice to define and to detect an early PML, because an early PML gives you a strong diffusion, hyperintense signal, no restriction, no ADC change in the beginning, and that at a stage, and that is all caused by the demyelination, and that all without a strong flare signal. So you don't have edema, you don't have an inflammatory reaction, but you do have this strong signal from the demyelination in the beginning, and this mismatch of flare, edema, and demyelination on the diffusion gives you a strong hint that there's a PML ongoing and not a MS. And the relation between flare hyperintensity and diffusion hyperintensity, that changes over time. So you can also get some hint on the age. So the longer the PML lesion stays, the less intense it is on diffusion and the more hyperintense it becomes on flare. So whenever you think that that might be differential diagnosis, or better in clinical routine, just have the use the diffusion sequence in as part of your routine setting. And a flare, very helpful, very helpful. Okay, another feature of the PML are these what we call punctate or Milky Way lesions. You see them nicely here. I admit it's again a 7 Tesla image, but you see them also at 3 Tesla. So dotty punctate lesions that might sometimes enhance, and that we see not only adjacent to the PML, but more diffusely spread. So these can be a nice hint to a PML as well. And if you're lucky and have extremely good imaging, you may see have these findings. So dotty structures subcortically and cortically. This is a very early PML and how it evolves. So there are paramagnetic changes due to the demyelination in the early instances, and they are sort of cystic. That's again one of the features of the PML, that you have microcysts and then heterogenic appearance opposed to the more homogeneous MS lesion that is well delineated. Okay, so that was the PML case, and I hand over to Roula, if I can. Stop. There we go.
So we go back to our cases. I will share my screen. Well, let me see. I didn't open my presentation, so that's it. Why? Why it's not? I can't see my presentation. Ah, probably this one. Share. Okay, that's fine.
Yes, it's fine. Now you put it on, yes, presentation mode, okay. Perfect.
So we go back to our cases. So this is the case number 7. 60-year-old patient known to have hypertension, presented with severe headache and difficulty walking. And this is his MRI. So I put here axial flare images, 4 axial flare images of the brain. So on those flare images, we have confluent lesions in the periventricular white matter. But here we see that those lesions are not touching here exactly the wall of the ventricles. There are other lesions here in the basal ganglia and the deep and superficial white matter. Another bunch of flare images showing also subcortical lesions. We don't have juxtacortical lesions, so there is no involvement of the U fibers. And the lesions are subcortical, diffuse in the white matter. So he is 60-year-old hypertensive. So what's your differential diagnosis? What's your diagnosis? Is it MS? Because I don't see here. Is it chronic small vessel ischemic disease? Is it cocaine abuse, white matter changes, or migraine with white matter changes? So what do you think? So 60-year-old hypertensive, headache, a lot of white matter changes in the brain. Do you think this is MS? So nobody said MS. So this is
close in 5 seconds.
Okay.
Isn't it an MS talk? It's a talk about MS.
Yes, but we should speak about the mimickers of MS. So a lot of white matter lesions. Is this MS? we should call it MS. Correct, we should not call it MS. So this is a chronic small vessel ischemic disease. Well, at 60-year-old, migraine might be, but usually we see those white matter changes mainly in patients with hypertension, above the age of 50, a lot of white matter changes that are age-related. So the diagnosis of MS is very difficult above the age of 50. Because most of the common white matter lesions are related to small vessel ischemic disease. And especially we see it in hypertensive patient and patients, diabetic patient. So this is a case of small vessel ischemic disease. And here I put for you a small comparison in a table how to differentiate MS lesion from small vessel ischemic disease, mainly in patients above the age of 50, because above the age of 50, we have a lot of white matter lesions. So in MS, typically the lesions are in the optic nerve, juxtacortical, involving the U fibers, at the periphery of the brainstem, involving the spinal cord, periventricular lesion touching the wall of the ventricles, the Dowson finger, the presence of the central vein sign, and cortical, presence of cortical lesion. However, in small vessel ischemic disease, those white spots, because secondary to leukoariosis and small infarctions in the white matter, they spare the U fibers, so you don't have juxtacortical lesion. They may affect the pons, but the central area of the pons, and not the periphery of the pons like in MS. And usually small vessel ischemic disease spare the corpus callosum and the callosociptal area, because the corpus callosum is very well vascularized. So it's very difficult to have ischemic lesions in the corpus callosum. And for the periventricular lesion, typically we have normal white matter between the lesion and the wall of the ventricle, in contrast to MS lesions that they touch the wall of the ventricle. And in small vessel ischemic disease, we have associated lacunes and microbleeds. And we see frequently widening of the Virchow-Robin spaces in the basal ganglia that we see mainly with aging. We can have cortical infarcts, so the cortical lesions are not really helpful here, but we have a lot of white matter lesions in the subcortical white matter basal ganglia with restricted diffusion in case of a lacunar infarct, and relatively are stable over time, the small vessel ischemic disease. So they don't change a lot from a year to another, in contrast to an MS, inactive MS patient. So we move to our next case. 60-year-old patient presenting with tingling and numbness in the lower extremity. And this is his MRI. It is a female patient, so tingling in the lower extremity and numbness in the lower extremity. So this is the MRI of the patient. So we have high signal flare images. So those are axial flare at the level of the brainstem, at the level of the external capsule, temporal lobe, and centrum semiovale. So there are a lot of white matter lesions in the centrum semiovale. Some are periventricular, touching the wall of the ventricle. We have lesions in the external capsule and in the subcortical white matter of the temporal lobes. So what's your diagnosis here? Is it MS? Is it vasculitis? Is it infection or small vessel ischemic disease? So it is a female patient, 60-year-old. She has a family history also. I can give you a hint. Family history also of strokes, presenting with tingling of the lower extremity.
Okay, 10 more seconds and then we close.
Okay, so it's correct. So the correct diagnosis is vasculitis. It's not MS. We did laboratory work for this patient laboratory test. They were negative for infectious and autoimmune disease. And the final diagnosis was a CADASIL, a type of vasculitis. It's a cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. So this patient has a family history of vasculitis and was diagnosed with CADASIL. And the key points here for CADASIL, the typical imaging appearance, that we had lesions in the basal ganglia. We have periventricular white matter lesions similar to MS, but the typical lesions are the presence of subcortical temporal lesions along the temporal poles. So typically when you see white matter lesions in the subcortical white matter of the temporal poles bilaterally and white matter lesions in the external capsule, you should think about CADASIL and not about MS. And also the lesions in CADASIL are confluent, large lesions, and they're not ovoid, as Jens discussed it before. They're not small, punctate, ovoid, oblong lesions in the periventricular white matter. So CADASIL is a vascular disorder. Patient usually they present with progressive degeneration of the smooth muscle in the blood vessels. It's more common in female above the age of 40, 50. Usually patients, they present with headache. They have a family history of strokes. They have by imaging multiple white matter lesion and infarction. And usually they have early dementia. And also they have symptoms of migraine. And if we do T2 star or SWI susceptibility weighted imaging, we can see microbleeds, like in all cases of vasculitis, small area of microbleeds in the white matter. So vasculitis, it's a big mimicker of MS. One of them is CADASIL, as the case I showed before, but there are other CNS vasculitis that can mimic MS, mainly vasculitis associated with autoimmune disease like lupus erythematous, rheumatoid arthritis, Takayasu disease, and primary angiitis nodosa. There's also the primary CNS vasculitis, and the drug abuse, ketamine and cocaine, that can cause also vasculitis, giving white matter lesions that can mimic MS. This is another case of CADASIL, just to show you the typical appearance. So when you see confluent large white matter lesions in the subcortical white matter of the temporal poles and in the external capsules, beside those white matter changes in the basal ganglia and periventricular white matter, so the pattern of white matter should be suggestive of CADASIL. The presence of a family history also is a hint, and the age. So female patient above the age of 50, you should think about CADASIL. We move to the next case, 27-year-old patient presenting with right-sided weakness and decreased eye motility and pain. So she got not optic nerve, but oculomotor nerve problem and right-sided weakness. So this is her MRI. We have axial flare images at the level of the brainstem, at the level of the cerebral peduncle, so lesion in the left cerebral peduncle that's showing restricted diffusion, high signal on diffusion, low signal on the ADC map. So it is a restricted diffusion lesion in the brainstem, so probably an infarct. There are also other lesions in the left thalamus and the left periventricular area, also some of them showing area of restricted diffusion, low ADC map. So it is a young patient. She's a female, 27-year-old, with those small areas of strokes. So what's your diagnosis? Vasculitis, infection, MS, or I don't see the last, drug abuse, because I have the pool inside. So what's your diagnosis? Young with a deficit, with strokes, small strokes in the brain.
Okay, we close in 10 seconds.
Okay, So most of you said it is vasculitis and it is the correct diagnosis. So now we have to work up this vasculitis and see what's the cause of the vasculitis. Of course, drug abuse can be a cause of vasculitis, but in this case, the history and the lab tests were negative for any drug detected in the blood and urine. Infection was not on the differential, and you got it right, because there is no meningeal enhancement, there's no abscess formation. It's not MS because the lesions are confluent large, involving basal ganglia and adjacent white matter. Restricted diffusion can be seen in MS, but the size of the lesion, the confluence, is not typical of MS. So this is a case of vasculitis. We did the workup for this patient. She had positive anticardiolipin antibody, low C3 and C4 complement levels, elevated B2 glycoprotein antibodies, positive lupus anticoagulant, and marked elevation of the ESR. So this was a case of systematic lupus erythematous with vasculitis, secondary vasculitis in the brain, and small strokes in the brain. So systematic lupus erythematous can cause vasculitis in the brain. It's an autoimmune disease. It presents with multiple white matter lesions on MR, with infarcts, with acute infarcts, showing restricted diffusion like in our case. And you know the infarcts at day 4 because of the rupture of the blood-brain barrier. You can see contrast enhancement in those infarcts. MRA, if you do it, you can see arterial stenosis. But if the stenosis is involving the distal vessels, MRA might be negative. So a normal MRA will not eliminate vasculitis. In those cases, we go and do the usual DSA angiography. With the time, we can see cortical atrophy because of the white matter changes and the infarction at the brain, ventricular dilatation, infarction, and hemorrhages, microhemorrhages like in all vasculitis. We move to the next case. A 57-year-old female presenting with right-sided weakness. So right-sided weakness, and this is her MRI. This is her first presentation. It was in April 2010. So right-sided weakness, there is a lesion in the left basal ganglia, high signal on flare, patchy, mild enhancement after contrast administration. So here, we didn't have a definite diagnosis. It can be inflammatory lesion, demyelinating lesion, vasculitis, tumor. She was treated with steroids and she improved. But she came back in November 2010. You see the axial flare at the same level as the previous one. So the lesion in the basal ganglia decreased significantly. There is some atrophy. And now she has a new lesion in the medulla. So there is a new lesion in the medulla and the brainstem. And if you look to the size of the brainstem in this patient, there is atrophy of the brainstem. So lesion in the basal ganglia previously that disappeared, atrophy of the brainstem, and a new lesion in the medulla later on, a few months later. So what's your differential? What's your diagnosis? Is it MS? Is it infection? Is it Behçet disease or sarcoidosis? Or lupus, sorry, SLE, lupus. She is 57-year-old.
Okay, still 10 seconds and then we close.
Okay, so it's not an MS, correct? Because of the appearance of the lesions, it's a large confluent lesion in the basal ganglia as the previous case, so it's not MS. We don't have the small ovoid lesions in the periventricular juxtacortical white matter, no optic nerve lesion. It's not an infection because it resolved, the first episode resolved without any antibiotics or antiviral treatment. It is a Behçet, it is a neurobehçet case. Well, SLE, it's not a lupus case, even though that differential diagnosis is difficult. So it is an autoimmune disease. And here we should do labs to differentiate lupus erythematous from Behçet disease. So it is a neurobehçet. The patient was treated with prednisone. And it is Behçet because of the typical appearance of the typical location of the lesion. So patients with Behçet, they have a neurological involvement in 5 to 30% of cases. Neurobehçet is divided into two groups. So we can have parenchymal lesion or leptomeningeal lesions. So the parenchymal group lesions, mainly it involves the brainstem, like in our case. So there's involvement of the brainstem, involvement of the basal ganglia, which is very suggestive of Behçet. So when you see involvement of basal ganglia and brainstem, you should think about Behçet. You can have also other white matter lesions, cord lesion, lesions like meningoencephalitis, and occasionally large infarction. And we have the leptomeningeal, the non-parenchymal lesions. The non-parenchymal type of lesions, 20% of cases, they include dural venous sinus thrombosis, because Behçet can give inflammation of the arteries and the veins. So you have vasculitis involving veins and artery at the same time. So we can have dural venous sinus thrombosis or arterial occlusion or aneurysm secondary to vasculitis in a neurobehçet patient. So Behçet can cause either vasculitis, venous infarct, or arterial infarct, or parenchymal lesion. And typically the parenchymal lesion, like in our case, are localized in the basal ganglia and brainstem. So here it's just a repetition. Lesions in the brainstem, internal capsule, and basal ganglia are very suggestive. And the serial imaging in neurobehçet show atrophy and the change in lesion shape. 7% of the lesions are enhancing. And this is another case of Behçet, a typical large lesion involving the basal ganglia, some focal area of restricted diffusions due to involvement of the vessels and infarctions within this large parenchymal lesion. There is also ischemia due to involvement of arteries also, because Behçet can cause also vasculitis and arthritis. Now we move to the last case. It's a 34-year-old male presenting with sudden onset of painless blurring of vision. So blurring of vision, painless. And 1 week later, he developed vertigo with ataxia, followed by tinnitus in the left ear. So this patient is presenting here optic nerve probably problem, and also problem related to the inner ear, vertigo, ataxia, and tinnitus. So we did MRI for this patient. So this is axial and sagittal flare of this patient. So we have lesion here in the corpus callosum, mainly in the splenium of the corpus callosum, another lesion in the interior aspect of the corpus callosum. And this is T1 with gadolinium. And we see there's one lesion in the corpus callosum not enhancing, and another one faintly enhancing. So what do you think? What's the diagnosis? Is it vasculitis? Is it MS? Is it Susak syndrome? Is it Markia-Fava-Bignami disease? Or is it a transient lesion of a transient splenial lesion of the corpus callosum, the lesion that we see transient and reversible in the corpus callosum?
We'll stop in 5 seconds.
I always thought Susak is a very rare orphan disease.
It is rare. It is rare.
I'm surprised.
I just have 2 cases.
Here.
I just have 2 cases. So, well, it's not a vasculitis because most of the lesions are centered in the corpus callosum. And as we said before, the corpus callosum is very well vascularized. It has vascularization from the anterior cerebral artery and the posterior cerebral artery. So vasculitis will not start at the level of the corpus callosum. It's not MS because the lesions in the corpus callosum are in the center of the corpus callosum and not in the periphery of the corpus callosum. It is a Susak syndrome. It's not Markia-Fava Bignami because there's no history of alcohol, no seizure, and the lesions are tiny punctate. In Markia-Fava Bignami, the lesions are diffuse confluent in the corpus callosum. And they're not transient splenial lesions because there are multiple in the corpus callosum. Usually the transient splenial lesion is just one lesion in the splenium of the corpus callosum. And usually we see it after seizure, status epilepticus, disruption of epilepsy medication, or in some medication like metronidazole. So this was a case of Susak. We did the fluorescein angiography for this patient. There was a delayed filling in both eyes with multiple areas of bilateral vasculitis and multiple arterial obstruction in the retinal arteries. And the CSF glucose was normal and protein 0.54. So this is a case of Susak. We have another case of Susak, also patient presented with sudden onset of confusion and agitation. Eye exam showed papilledema, and this is the MRI of the second patient. Similar to the previous one, lesions in the corpus callosum. There are lesions also in the white matter, in the centrum semiovale, and those lesions in the corpus callosum are in the center and not the periphery, and they're not enhancing. The angio of this patient, MR angiography, was normal. There was no stenosis. So the key points for Susak, it's a microangiopathy affecting the brain, the retina, and the cochlea. So if you have patient presenting with retinal symptoms and cochlear symptoms and lesions in the corpus callosum, you should think about Susak, even though it is rare. They said it's more common in female, but we have male cases here. The etiology is unknown. So we have predominantly supratentorial lesion. The lesions in the corpus callosum, usually they spare the periphery, mainly they are in the center of the corpus callosum, and we can see small white matter lesions like MS. They can be similar to MS. So it's a big mimicker of MS, Susak. Here a case from the internet. To show you just the angiopathy at the level of the retinal artery, stenosis, irregularity, and microaneurysms, irregularity in the retinal arteries, and the lesions in the center of the corpus callosum in Susak. So here, I will discuss here all the conditions that we show here that can mimic MS. We can have CNS inflammatory lesions like edema, that we see it mainly in kids after viral infection or vaccination. Sarcoidosis, Susak syndrome, and Behçet syndrome are inflammatory disease that can mimic MS. Infection can mimic MS, HIV, PMN, like the case Jens showed before, Lyme disease, that is very common in the US, syphilis, toxoplasmosis, mainly in immunocompromised patients. Vascular diseases of the CNS can mimic MS, mainly chronic microvascular disease that's most common in patients above the age of 50 and mainly seen in patients with hypertension, diabetes. Cadazil also is a big mimicker, but the key for Cadazil, as we showed before, the family history, the location and the subcortical temporal white matter and external capsules. Other white matter lesions that can mimic MS, iatrogenic causes like chemotherapy and radiation therapy, but in those cases, usually the white matter lesions are confluent and not ovoid, tiny, punctate, periventricular. And other metabolic and genetic lesions like vitamin B12 deficiency and leukodystrophy. And I finish here with my cases and give the floor to Jens.
Well, we may have a very quick discussion whether we A, want a bio break, B, as we run a little bit late, how to continue. We would have still two topics to cover, atrophy and smoldering disease, slowly evolving lesions. If we do both, it will take another half an hour. So I would ask Stefan to put up a quick poll and get the participants' opinion on how to extend from here. So we can skip one of the topics, save some time, just trying to understand your interest here, or have both, but then we need another about half an hour. If Celia agrees to that, because
yes, I agree. You can have 20, so I think until 18:30, so you have half hour. I can do mine 20 minutes. It's not a problem.
Well, we have a clear winner, I would say, in the poll.
Yeah, which is I cannot see.
Which is the smoldering lesions. Okay, we skip atrophy.
I think it's more fascinating.
Okay.
This is very current problem now. Everybody wants to know about the smoldering lesions.
Okay, let me switch to my slides.
And then we take a short break after you have finished, Jens.
Okay, yeah, that's fine with me.
Yeah, and then we go to Professor Oreja. Okay.
Okay, but let me still advise you that atrophy becomes more and more important. So whenever you have the chance in your clinical practice, please put a 3D-T1 with a good gray-white differentiation as part of your routine scans. It will be helpful in the future. You will have in the future to go back and have original scans to compare with in a couple of years. So it's very important that you stick to that. But I understand it's not your key interest, so let me move to another topic, which is the microglias and macrophages fate. The innate immunity and smoldering disease has become a topic widely discussed, not only by Gavin Giovanni from London, but from many sides. And I'd like to guide you a little bit through what is behind that. So you know that initially there's some microglia activation at the site of tissue damage, and then cytokines are extravasated, and there's pro-inflammatory environment, and the microglia clears the debris, and microglia also takes up, clearing the debris, also iron that becomes free after the oligodendrocytes are damaged and myelin is destructed, because oligodendrocytes contain a lot of iron. And usually in the cascade there's a shift after a couple of days, weeks, a profile shift from this anti-inflammatory microglia to a anti-inflammatory microglia. So from this proactive reacting microglia on the inflammation, there's a shift to an anti-inflammatory microglia. And that induces the repair and also attracts oligodendrocyte precursor cells that take part in the repair and in the remyelination. And that prevents gliosis formation. Now, in the rare instance that this shift is inhibited, interrupted, and we don't understand yet clearly the mechanism to that. But if there's no shift towards an anti-inflammatory environment, then there's a chronic intrinsic inflammation that is not stopped, but goes on and on and on and on over years, with the result that you have, independent from the periphery, an intrinsic inflammatory activity surrounding this lesion. That causes the lesion to grow slowly. And you see this activity because there is active and iron-laden microglia and macrophages surrounding this lesion. And we believe this is one of the mechanisms that cause this chronicity, like not the relapses, but the chronic inflammatory process. And that part of the process that is not only chronically inflammatory, but also involved in the degenerative process. And that is something that the pathologists can show you by histology, as you see here, an active and inactive lesion. And you see I don't see it because I have a full slide here in front of me. No, I cannot shift that. Anyway, I hope you see the macrophages labeled here. And there's macrophage rim that forms surrounding this lesion. And this is what the pathologists tell us. Well, this is, even after 10 years, this is still active. There's an active inflammation ongoing. So this is a chronic active lesion. And we see that, or the pathologists see that in the majority of MS cases. And the nice thing for us radiologists is that we can visualize these macrophages, because iron causes such a strong susceptibility and it's such a good marker in MR. We can visualize the iron-laden macrophages in the iron rim, and that is what we call the hyperintense rim on chronic active lesions. And there's a different aspect that we can also measure and quantify, and that is this growth. And these slowly expanding or slowly evolving lesions, they grow very, very slowly. So you need a couple of years to see that they're actually not constant, they're not shrinking as they usually are if there's lots of gliosis, but that they are growing over time. And there are some mechanisms or some algorithms like Jacobian algorithms to help us detect this very slow but constant grow. And it's important to understand that the growth needs to be constant and concentric over time. So that's, it's not relapsing. It's not new inflammatory activity, but it's ongoing, slowly disease activity. And that is truly something that we see and that has been used in trials, also in treatment trials already, as a parameter. And I wanted to draw your attention to this factor because I believe it's only one little thing and one little parameter that shows us that there's chronic activity in MS patients. We see that in other parameters in the normal appearing white matter as well. Like if you look for the ADC change over time in normal appearing white matter, if you do spectroscopy on the normal appearing white matter, if you look for magnetization transfer changes, on perfusion changes, etc. There are many parameters that we call advanced parameters that show you that there's a chronic ongoing disease, even starting at clinical isolated syndrome, but very, very early in the disease. When it seems that this is the part that triggers the neurodegeneration, and it's also obviously an important part that is correlated with the clinical disability and the accumulation of the clinical disability, in addition to the focal and relapsing activity that we see in MS. So this is a key point, key learning I wanted to give you. There's intrinsic activity, inflammatory microglial activity that we can visualize nowadays. And if you have the chance to run a SWI, susceptibility weighted imaging, or T2 star, you may be able to catch exactly these iron rims, these hyperintense rims, that most probably become an important part of our evaluation in the future. Celia, another 5 minutes for me to jump a little bit further into 7 Tesla imaging, just because it's so beautiful.
Yes, no, you have until 6:30, so you have 20 minutes.
Okay, I'll continue a little bit
yes.
on topics. So,
no, my talk is short. You don't worry.
The beauty of the high field strength is that you can use it for very good resolution. And you can use that resolution. This is just an MP-Raytron T1 weighted image, and you can use the resolution to to show different areas and of the white matter. For example, this area was obviously destruction. So this is what I would call, if it stays constant, a black hole. So destructed tissue, but you've got also areas that are less dark, and then areas that are very little dark. And if you compare such findings to what we see in histology, it's exactly what the histologists tell us. Well, these are various degrees of de and remyelination. And we can use these images to in vivo estimate whether there's ongoing or how much there's demyelination, whether there's an ongoing remyelination. It's something that is, using other means, even DTI and what have you, very, very tricky. And that's the beauty of the 7 Tesla. The other nice thing is that you have got a very strong susceptibility, and you can use this susceptibility, of course, to display bundled fiber tracts just by the architecture. They appear dark. This is the optic radiation visual system. You can show hyperintense rims. You can show, I don't see it because I've got another thing in advance of me, central veins, for example. And this is one of the causes why we became so attracted by central veins, because we noticed using 7 Tesla imaging that it's so frequent in MS. At 7 Tesla, each MS lesion has a central vein, we have to say, and it's so specific and characteristic for MS that it became part of our diagnostic procedure workup nowadays. And we can use that also, of course, not only at 7 Tesla, but with routine field strength. Well, it's easier at 3 Tesla than at 1.5 Tesla, I have to admit. But if you spend some time and fuse a flare and T2 star S2WI, you can overlay those and nicely depict lesions that have a central vein. And if you've got, if you find 3 or 4 of these central vein lesions, the probability that you have an MS patient in front of you is extremely high. So having skipped atrophy, I think we get you some take-home messages. Now I need to try to get that away. Yeah, okay. Roula, should I go through that? Is that fine?
Yes, of course. Go ahead.
Okay.
Yes.
So hopefully, as a summary, we could show you that MRI is extremely important, helpful, and fun to diagnose our patients, to find the right differential diagnosis if it's not MS, and extremely helpful to longitudinally monitor patients, because we are so sensitive. We see 10 times more lesions than clinical symptoms. So every 10th lesion in statistics causes symptoms only. But please, please do avoid too much bias, and you can steer that to quite a good amount by keeping conditions constant, using the same scanner over time, the same head score over time, the same sequences and the same angulations over time. It's so helpful. It gets a little bit easier if you have the chance to use 3D sequences like a 3D flare, 3D T1, then the angulation is not that big of a deal anymore. Roula showed you that the 2017 revisions of the McDonald criteria are very helpful in clinical practice. They revitalize the role of the CSF analysis and reconsider the value of typical imaging findings, in addition to findings previously not included, right? The symptomatic and the cortical lesions were added 3 years ago. Take some effort to identify active lesions, disease progression, and for my part, I would suggest please start quantifying atrophy if you have the chance, if you have either a commercial tool or you could apply Sienna, for example, as an easy method yourself and get some hands-on experience in that. I promise you it will be an important parameter in the future to consider. So even if you don't consider and measure and quantify it now, please put a 3D-T1 sequence as part of your routine sequences. It's very helpful for the anatomical structure, for differential diagnosis, and in the future also for atrophy. There are many, many disorders that mimic MS that Roula guided you through in this excellent and huge summary of differential diagnosis. Please be aware of the red flags that she showed you to understand and see the differential diagnosis. Understand the white matter pattern in MS and its mimic, because they require completely different therapies. So you have to be aware of that. Smoldering disease is a mechanism that came into focus recently, and I'm sure you will hear more about that in the next years. And most probably that is one of the links to the neurodegenerative component of MS. And as a hint from my end, please be aware of future treatment communications, because at the moment many people are looking, or many companies are looking into these new disease components, especially the chronic progression, the neurodegenerative component, and try to correlate that with the disease activity, and hopefully we will find some future and have some evidence in the future, find some therapies that improve these disease features in our patients. And with that, I think we are open for discussion, and I would like to thank you for your participation. There's a survey to fill in. I should remind you on that. And now I stop my screen and return back to you. And Roula and me, we are open for questions now.
Yes, in the case that somebody has a question, you can do by the chat, or you can speak direct. Because I do one question, Jens. Do you think that really these smoldering lesions are so important? Because now it's like everybody needs to look to the smoldering lesions, yeah? And I don't know, it's more so a marketing thing, or it's really an important thing for the radiology, an important thing for the MS?
I'm not sure whether they are already important for us on the radiological side, but for sure they are one small hint that there's a process that is ongoing in MS, and that we have in every relapsing remitting patient also a component that is chronically active and progressing, and for that it's helpful, but we don't see them in every patient, and I'm not sure whether it will be the clue for the future in our patients, or whether that differentiates enough, because my understanding is that we have this chronic component probably in every patient, even though the symptomatology is only relapsing.
So that you think that really we cannot say that these smoldering lesions, they are a sign of demyelination or a sign of neurodegeneration, is not so clear, or yes?
Well, they are a sign that there's an intrinsic inflammation ongoing. That is the thing. So it's not based or not focused on relapses, but there's a chronic process. But
so do you think that we can use this to, for example, when we have a new neuroprotective treatment or something, so neuroregeneration, so for the regeneration, we think we can use this kind of lesions?
I'm not sure whether they're a good readout parameter,
yes,
for treatment efficacy. But from the pathophysiological side, they're interesting.
Yeah. Okay. So more questions? So somebody, good evening, everybody. So for the people that don't know, that is a meeting between MENACTRIMS and ParadigMS together, and Professor Basel was explaining before what is MENACTRIMS and what is the importance of this Congress. And ParadigMS is a foundation with expert neurologists in multiple sclerosis, and we are doing education. So we are doing a lot of PowerPoints, slides, talks about different subjects of MS, and one of the most important goals that we have is education on multiple sclerosis for the different healthcare professionals. So, and now we try to do everything virtual, because before they were face-to-face, and now we try to do this experience in virtual. So we have a homepage. So from the case that when you finish today the meeting, you want to find things there, we have a new homepage, and we will try to put all of our material in the homepage. So I will do a brief summary about how to manage the team and the patients during the pandemic. So I work in Madrid, in Spain, and as you know, Madrid was one of the hot spots in the first week of the pandemic. We, together with Milan, I think we were the most affected cities in Europe, so that we have a lot of experience, unfortunately. But now for the second wave, we were much better, so that we were prepared, and I think some of the part of the society, they have immunity. That was another thing. So here is our hospital. Our hospital is the oldest hospital in Madrid. And there's university hospitals. We have a lot of beds, 700 beds and 220 places in the day clinic. So in Spain, the system is that we have every year less beds, but more places in the day clinic. We try to do more things in the day clinic, and we try to do less things in the hospital area, so that we have every year less and less hospitalized patients, and we try to do everything in the day and not to have the patients more too many hours in the hospitals. We have 53 medical departments, and we are together with that is really the biggest university Complutense, the biggest university in the whole Spain, and it's the University Complutense in Madrid. So here's our hospitals, and we have 1,700 patients with MS. And from these patients, we have 1,450 with therapy, 46 patients with NMOSD. And in Spain, it's a little different from other countries. We treat all the patients in the hospital. It means they pick up the medicines in the hospitals. They don't pick in the out pharmacy, so that they need always to come to the hospital to receive the medication. So we do MS consultation every day. And the infusions, all the monoclonal antibodies we do in the day clinic. So that's the whole care of the MS patients is in the hospital, and it's not in the outpatients ambulatory or in the other physicians like in other countries. So when we have the first wave, so that is completely different, I think, for the countries that they are in different waves now. So we were in the first wave. I think now we are to finish in the second wave, and probably we will receive the third wave for December. So that I think the worst thing that was at the beginning. I know now in Europe, many countries in Europe, they are having now what we have in the first wave. But so the problem in the first wave that was the uncertainty, and I think now it's completely different. Everybody knows what is happening. We know a lot about the virus. We know a lot about the medicines, the treatments, so that now we have learned a lot. So that now it's completely different. I know so many countries that in the first wave, they were with a very low number of patients. Like, for example, Germany, now they have much more. But now the situation is completely different because we know the virus, we know many things. But the first wave everything was very unclear. So the problem was in the first wave that was March, April. We start at the same time like Italy, so in the at the beginning of March. Officially, probably we have patients from January 2020. And the problem was the risk of infections was very, very high. I think that is one completely different thing from now. That at the beginning, the viral load was so high in the hospital that was one of the important problems, yeah, the high load of the virus, yeah, in the hospitals. Now we see now we can measure this, and it's really it's low or very low. It's completely different situation now. So that because it was very, very high, we have closed the hospital for ambulatory patients. We have only the day clinic was open, the hospital pharmacy was open, and our hospital, I told before, we have 700 beds. But we put beds at that time point everywhere, in every waiting room, so that at the end in the hospital, there were 750 COVID patients, plus patients like heart infarct patients, some emergent, urgent surgeries patients, so that at the end was completely full, but completely full of COVID. Yeah, I have always the impression when I was in the hospital that I was breathing COVID, yeah, because it was too much COVID. So the problem at that time point that we have canceled the MRI, we have done very few blood tests, and the emergency department was completely full. Some days they were with 400 patients in the emergency department. So that was a situation that I hope that we will not see never more. So the problem was in the neurology that we have no more neurology ward, so disappear. We have only stroke unit. The stroke unit was working, but we have less strokes, not because the patients they were without a stroke, so because the patients they were not coming to the hospital because they were more afraid from COVID than from a stroke. The young neurologists, all the young neurologists and all the young physicians from all the specialties, they were sent to the COVID wards, and the senior neurologists were to the cleaning polyclinic in the near close to our hospital. There is a polyclinic. And there was clean, and we have done there the emergencies like relapses and other things. And the rest of the neurologists, we have done telemedicine for other pathologies. the big problem that was at that time point, and now we have again, is the problem is that many people from the staff, they have the infection, the COVID infection, so that they were not working. Some of the staff, they have quarantine, they cannot work, and later it's come the mood disorders, because when some of the staff, the physicians and nurses, they are working with COVID, at the end, many of them, they have anxiety, depression, so that at the end, one of the problems that was in the first wave, but now is more in the second wave, is that we have a shortage of a lack of the staff because of these three reasons. So they have COVID, or they have quarantine, or they have depression, anxiety, or other things. So that one of the big problems now is the staff, the lack of the staff many times. Our objectives in the first and in the second wave is to reduce the risk of the COVID-19 infection in the MS patients. So that was the reason he has wrote, is a mistake, is face-to-face. There was face-to-face visits. We have trying to avoid the MS worsening. We have always balanced benefit and risk. So the benefit to come to the hospital, for example, for an MRI, and the risk to have the infection of COVID coming to the hospital. From that time point, we have increase of the communications between the healthcare professionals and the people with MS, and we have always personalized our treatment decision. So one thing I think was important advantage of the pandemic is that we have now increased the communication between the healthcare professionals and the people with MS and with the association, so that now we have better communication channels between all the people in place on the care of the multiple sclerosis. The other important thing that is now, that was new, and that is now, I think, is coming and will stay with us, that is the telemedicine. So that we have, at that time point when the hospital was closed for all the patients that they were not COVID, we were doing a telephone consultation every day. We have now telemedicine, so we have more communication, as I said before, with all the healthcare professionals, all the associations, all the patients. And I think now, for example, that was in the first wave, we have no face-to-face consultation. Now we are having 60%. And it is clear that we have seen that really for some patients, they don't need to come every time to the visit to our hospital. So that really patients that they are stable, that they are young, that they really, they have no problems. It is enough when we are doing a telephone consultation, and perhaps we do a telephone consultation and next time a face-to-face consultation. But really, sometimes we have realized we don't need to see the patients 4 or 5 times in the year only to see how are you and is this thing. So that we have now we have seen that we can reduce some consultations, and the patients, many of them, they are happy not to come every time to the hospital and to see the physician, and they are happy when we call us. And they prefer in some situations that we call or that we do a video conference, but not to come every time to the hospital. Other thing that we have done, so at that point was the home delivery. We have sent the patients the medication to the home, and now we are still doing for patients that they have disability or that they are living far away from the hospitals. At that time point, we have this clean polyclinic to treat the emergencies, and in the case that we need to close again, we will do again. And what's important thing was we have in the most of the cases cortisone therapy was orally, and very few patients we have by a relapse in the first wave. We were doing IV corticosteroids, but we have realized that really the oral corticosteroids, 1 gram oral corticosteroid in liquid form, they are not so efficient like IV. I know there are 2 papers that they say that you can give 1 gram methylprednisolone IV, and you can do the same, and you give orally, and that is the same. But we have realized that it's not the same. That when you give orally 1 gram methylprednisolone, that is really less effective than when you give IV. So that was one of our experiences during the pandemic. And during the pandemic, we have the day hospital open, and we have given all the other IV treatments, all the monoclonal antibodies. So other important thing is we have changed in the information needs. The patients now, they are still calling a lot, but it was the different asking questions. At that time point, the patients, they were very scared because they thought they are immunosuppressive, and some of them, they have stopped the medication or they wanted to stop. But now it's different in this second wave. In the second wave, the patients, they will have continued with the treatment. And now think for countries that now they are in the second wave, but it's completely different than the first wave, like Germany or Switzerland. I think that now the patients, they know that they need to, they can continue the treatment without problems. Now the patients, they have realized that they could do rehabilitation at home. There was a lot of associations that they were doing rehabilitation online, and they have programs in YouTube, so that now the patients, they can combine rehabilitation by the associations in the hospital with rehabilitation online at home. And like always, we have done individualized approach to the decisions. So regarding the treatments, at the beginning was not so clear. We have always continued all the treatments. I know that in other countries and the first guidelines, they were different, and they say to stop some of the treatments also, but we, from the beginning in March, very similar to the Italians, we have decided to continue all the treatments, and we have stopped only treatment when the patient was with an acute COVID infection. But we have continued with interferon, with the oral treatments for the first line, teriflunomide and dimethyl fumarate, and we have only really stopped and discontinued the treatments when really the patient was with fever and other symptoms of the COVID infection. We have individualized all the cases, and for example, we have no second cycle to start during the pandemic, so that was not a problem. In natalizumab, we have changed in many patients the interval from 4 to 6 weeks to avoid the patients to come to the hospital, and we are still doing so that many of these patients, they have now 6 weeks interval and not 4, and we have realized we have done a short abstract for a congress that is at least our experience during the pandemic, and now that is the same effectivity for natalizumab in 6 weeks and in 4 weeks. So that, for example, I will recommend in natalizumab to do in 6 weeks in many patients, not in all of the patients. And I will not recommend to do oral corticosteroids in high dose for patients with a relapse. Fingolimod, that was the same, like teriflunomide and Tecfidera, we have continued and only discontinue in patients with COVID infection, acute COVID infection. Cladribine, we have postponed only the second cycle in some patients with acute COVID infection. And with the ocrelizumab, was depending on the activity patients that with a progressive course, they were with a progressive course and they were stable, we have delayed the treatment. So now it's completely different, the situation in Spain, at least in Madrid. I know in other countries now the second wave in Europe is worse than in the first wave. But we can tell them how it is, and we can teach them, because now we are in the second wave, and at least in the whole Spain is not so bad like in the first wave. And for example, in Madrid, the second wave was not so bad. I will show you. So in the second wave, the different thing is that we have a lot of PCRs, and as you can see here, the different thing is that we have more PCRTs. In the first wave, we have not. Now you do a lot of PCRTs, so that you think there are more patients with infection, but we are sure that in the first wave there were more. Only the problem was they have no PCR tests, and so we have no count all these patients. Now we see in the second wave more young people with the coronavirus, and most of them they are asymptomatic cases. We see more young people hospitalized, and there's a slow increase of the COVID cases. They are not so fast like in the first wave. And now in the hospitals, we are working in a parallel way. We have a non-COVID patients and we have COVID patients. They are separate. We can perform most of the surgeries. And as told before, we are face-to-face clinical consultation 60%, so that we still do in telephone, because for some patients that they are stable, I think it's a good thing. Young patients that they have work and they have a lot of duties with the family, and they're stable, they prefer to do not all the consultations face-to-face, so that they want to do some of the clinical consultations by telephone, so that we are still doing. So here is the curve of the second wave in Madrid, and as you can see, the big difference in the black is the first wave. You see that in 3 weeks, we were from 500 patients to 50,000 hospitalized patients in Spain, in Madrid. So you can imagine from 500, we have at the beginning of March, and 3 weeks later, we have 60,000 patients with COVID hospitalized. Yeah, not with infection hospitalized, that is worse. And as you see now, the pink line is completely different. Our peak in the second wave was in September. At the end of September was 3,700 patients, so around 4,000. That it was 1/4 of the first wave. the worst day. Now we are around 2,000 patients hospitalized. And as you see, the second wave, we are decreasing, but very slow, but we are decreasing so that now we have 2,000, so 50% less than at the end of September. So that is, I show you that for the other countries that they are now in the second wave. So here is our experience with the COVID patients, and that was from the first wave. That was 35 patients with MS, most of them with a mild to moderate course of the disease. 28 was relapsing remitting MS, and there was all of the numbers from EDSS from 0 to 8. We have only 5 patients that were hospitalized. 1 patient died. He was with an EDSS of 8 with secondary progressive MS, and he has a bilateral pneumonia. Now in the second wave is completely different. The second wave, most of our patients with MS, they are asymptomatic, and it's only because by chance they have done an PCR because somebody was ill or somebody was PCR positive, or they have contact, or they have a family with a PCR. So that now, because we are doing so many PCRs, 95% of our patients that they have COVID now in the second wave, they are asymptomatic, completely asymptomatic. And why in the first wave, the most of them, they were relapsing remitting MS, I think it's only because the patients with progressive MS, they were at home. Normally they have a higher EDSS and they were at home, and they were more in lockdown than the other patients. And you will see the same experience in UK. Here were the treatments. We have in our court, in our hospital, we have no difference between the treatments. And here are the numbers of Madrid. In Madrid, we have around 6,000 patients with MS. And we are near to publish our data. And we have from these 6,000 patients with MS in the first wave, we have 220 patients with COVID in the first wave. So until June, from March to June, 220. And the most that at that time point, we have not done every patient with PCR because it was not possible, it was not enough. And as you see here on the chart, that most of them, they were females. Around the age was around 45, and the most of them, they were relapsing remitting MS, because I told you before, the progressive MS patients, they were at home and they were not outside, so that they were taking care, and that was the reason. And most of the patients that they have COVID, they were without with treatment. There was very, very few patients without treatment. So here are the data from Madrid. You see that we have used all the treatments. It doesn't mean that the patients with the oral treatments, they were more affected. Not the thing is that we have a lot of patients in Madrid with teriflunomide and dimethyl fumarate. We haven't seen difference when we have done the statistic. We haven't seen difference like in Italy or in the MS Alliance. We haven't seen difference between all the treatments regarding the evolution of the COVID infection in our patients. That is from the 200. So when you think from 6,000 patients with MS in Madrid in the first wave until June, we have only 220 they were with COVID, really with infection, and only 5 patients died. And all of them, as you can see here, there was secondary progressive MS patients, and only one of them, they were in the one relapsing remitting MS patients was in the intensive care unit. And as you see, the EDSS, they were in all of them very high. So that we can confirm the same, like in the English and Italian and in the French register, that the patients with MS, that they have a bad evolution, a worse evolution of the disease, that patients with a higher EDSS and patients with progressive MS. And I have brought here the UK register, because the UK register, I think the interesting thing is that here is this, they have a register with 5,000 patients and 500 they were with COVID self-diagnosis. And the interesting thing is that in yellow, you see the patients that were with PCR and they have COVID in the first wave, yeah. And when you look in the red, there were the patients with COVID that they have self-diagnosis, not PCR. And you see in the middle, the line of the patients, the UK general population that you see is the same pattern. So it's the same trend. It's a very similar trend in people with MS and the general population regarding the infection, so that the patients with MS, they have no more risk to be infected with COVID than the general population. So that I think is very important, this chart. And the other things from the UK register is that they have seen that the patients with a higher EDSS and the patients with progressive MS, they were a strongest predictor of self-isolation, the same like in Madrid. We have seen that the patients with higher EDSS, they were at home, they were not out, and that was the reason why they were not with COVID. And that was a physical disability or taking DMTs, they were not associated with increased likelihood of contracting COVID. So the physical disability is related with the worst course of the COVID infection, but it's not associated with the probability of contracting COVID. So from the French register, the French register is the important thing. They have 350 patients with COVID in the first wave. And the most important thing was that it was very clear that the age, older age, the same like in the general population, is a high risk factor of severe COVID infection. The higher EDSS, the progressive MS, and the obesity, they are the factors that they are doing that the patients, they have a risk of severe COVID-19 infections. And the same was for the Italian register. In the Italian register, they have seen the same, that the patients with a higher EDSS, patients with they were older, they have more risk to have a bad prognosis, a bad evolution of the COVID infection. And the other important thing, in Italy, they have 784 patients with COVID. And the other important thing is the Italian cohort and the MS Alliance register. They are the only two that they have seen some difference between the treatments. They have seen that the patients treated with interferon, they were associated with a reduced risk of COVID-19 infection. And the patients with ocrelizumab, they were associated with an increased risk. And they have seen that the patients treated with anti-CD20, they were associated with an increased risk of severe COVID-19. Very similar results are the results from the MS Alliance that they have now more than 1,500 patients. And with this slide, I am finished. So the take-home message of my presentation was that we have changed a lot with the pandemic. Now we do a lot of telemedicine. We have a better structure in the hospital and in the MS centers. We have better communications with the patients, with the patients associations. We have now we try to be more efficient in our in our MS center. And the other thing is clear: the patients with MS, they have no more risk to be infected with COVID. But and they have, in general, the patients with MS, they have a mild to moderate course of the COVID infection. And it seems that the patients treated with the anti-CD20 agent, ocrelizumab and rituximab, could be that they are that is associated with an increase of severe COVID-19. And what is clear, the older age, the progressive MS, and the obesity, they are clearly related with a worse evolution of the COVID-19. And that was all of my presentation. Thank you very much. And in the case that you have questions, you can do now. So probably you are very tired from the whole 3 hours. I don't know if somebody has a question.
Yeah, this is Jens. I would have a quick question to you out of curiosity. There are some hints on teriflunomide that it's also antiviral active. At least it seems to protect a little bit against PML. Do you have any data on COVID and teriflunomide that support that?
So the problem is that we have only the patients that they have COVID with teriflunomide, but we don't have the number of patients, total number of patients with teriflunomide in Madrid. So that we cannot say, so we want to do now, so retrospective, to look, so that we cannot say that the patients with teriflunomide, they have less COVID infection and they were with a better outcome. We want to try to do now because really in Madrid, there is a lot of patients. So in Italy, it's different. In Italy, the number one of the oral therapies is Tecfidera. In Madrid is teriflunomide. So that really is a good place that we can look now retrospectively to see if really the patients, because we have a lot of patients with teriflunomide in Madrid, so to see if really when we compare the groups of all the treatments, really our patients, they have less COVID infection or they have a better outcome. We will do now after that. I know in the last weeks, Sanofi was speaking about the antiviral effect of teriflunomide. Yes. So I don't know if somebody has a question, Basen or somebody from the audience. I don't see nobody in the chat, so perhaps we can close. We are near to 7. So thank you very much for attention. Thank you very much to Jens and to Roula for the very interesting workshop. I think we can repeat again, perhaps not on Saturday afternoon, perhaps on the day in the week, perhaps on Wednesday or some other day in the week. I think that this will be very interesting for many of the neurologists and many young neurologists. And thank you very much to the participants to stay to the end, and you were participating in all the pools, and you were very active doing with the pools. And thank you very much for the technical performance. So thank you very much, and have a nice Saturday. And